Good afternoon, everyone. I welcome you all to the CPC for the Department of Otorhinolaryngology and Head and Neck Surgery. It is an honor to invite today's discussant, Professor Nitin Nagarkar, Director of AIIMS Raipur and Head of ENT and Head and Neck Surgery Department at AIIMS Raipur. Professor Nagarkar has done his MBBS from Patna University, following which he did his MS from PGI Chandigarh, where he then worked as a senior resident as well. He was faculty in the ENT department of GMCH Chandigarh until he took on the position of director at AIIMS Raipur in 2012. Sir has had a distinguished career in the field and he has delivered many orations and has several publications to his credit. He is also a recipient of the Distinguished Service Award by the Delhi Medical Association. I welcome you, sir, to discuss today's case.
Thank you very much, and good afternoon to everybody. A special thanks to Professor Aanchal Kakkar, Venkat, Aanchal, my colleagues from the ENT department whom I've known for the last so many years. I'm sure that we've got faculty colleagues from departments of ENT, radiology, pathology, among others, as well as our residents who study here. So thank you very much. I think it's a very interesting case that we'll be discussing today. And I'll start with the first. So thank you very much. I'm working as the Director and CEO at AIIMS Raipur, but also with the additional charge at Bhopal AIIMS. But I continue to do my academic and clinical activities in places. So this again a very important and interesting, I think, case for all of us to learn from, which I'll be presenting today with the details which I'd received. The informants were the parents, and it was a 1-year-old, 4 months female child from Delhi, came with the chief complaints of nasal bleeding, bulging of the right eye, and right-sided facial swelling since July 2021. The child was apparently well till July 2021, and then the parents had noticed episodic fresh nasal bleeding, just a few drops, and it would generally start spontaneously, intermittent in nature. Dropwise, few drops of blood would come, about 5 to 10 ml, and would generally stop by digital pressure by the parents, the father or the mother. And it was never very profuse. So that's one point I think which is very relevant. The discharge wasn't there as such, it was only fresh blood, but it would stop on digital pressure, and there were no emergency visits to the local doctor. There was no history of trauma in the past ever, and more important, there was no bleeding from any other side. So what was noticed by the parents in the history of the presenting illness is important was bulging of the right eye with fullness of the cheek, widening of the bridge of the nose, producing a facial deformity. And the parents had noticed, because the child obviously will not tell that, was neglecting objects on her right side, obviously showing that there was diminished vision or decreased vision on the right side. The parents took the child to a local hospital, clinic, and they advised some nasal drops, thinking that possibly maybe some decongestant nasal drops were given, but it didn't control the medical condition. Nasal bleeds still persisted. Then they took the child to a children's hospital here in Delhi, where a CT scan was performed, which showed that there was mass in the nasal cavity, and thereafter referred to a tertiary care center in the same city, that's here in Delhi, where in that center a nasal endoscopic biopsy was done, but there was no clear histological diagnosis, so they had to repeat this biopsy twice, but still the diagnosis was not very clearly established, and the child was finally referred here to AIIMS New Delhi. The birth and development history was not significant in the sense that it was a full-term normal vaginal delivery. There were no genetic defects or syndromic associations at birth, and the developmental milestones were achieved at the normal rate, so that was not. So here at AIIMS New Delhi, when the child was brought, was admitted in the pediatric oncology department in September 2021 and underwent evaluation over here. The routine blood workup was done, and importantly a PET CT was performed, obviously having come to an apex center, and the child was given 1 cycle of cyclophosphamide based chemotherapy. So obviously there was, you can guess that some sort of concentration for a malignancy that time, but importantly there was no improvement in the clinical condition. So the symptoms still persisted, and thereafter the chemotherapy was there, abandoned, patient was referred to the ENT department here at AIIMS Delhi, and it was decided then to examine the child, and in the sense that biopsy and further evaluation could be done. So this happened in the month of October 2021. Clinical examination, I'll be showing the photograph also, was showed the right eye abaxial proptosis. That means the eyeball was pushed inferiorly and laterally with restricted movements in the medial, superior, and inferior gaze. So that was important. Right cheek was full, non-tender, and firm to bony hard consistency. Mass was felt on palpation. As I mentioned about the nasal dorsum being, widened right from the very beginning, that was also noticed. The pupil was dilated and non-reactive to light. Again, this corroborates with the fact that the parents had noticed that the child possibly was not seeing from the right eye, but the left eye was normal. And on oral cavity, there was no clear-cut bulge. That's one thing we will always like to examine, and no other lesions in the subsides of the oral cavity or oropharynx. Neck also examination has not been mentioned. We assumed that there were no cervical lymphadenopathy palpable that time. And more importantly, as far as the local examination was concerned, the nasal cavity showed a pink colored mass, the right nasal cavity, and it was large enough to push the septum to the opposite side. And if you see that the right side was almost completely obstructed because of the mass, and the septum was almost pushed to the opposite side, touching the lateral wall of the opposite. The general physical examination, otherwise the child was conscious, alert, active, and playful, with respiratory rate of 30 per minute. No signs of any airway distress, which is important, and pulse was 90 beats per minute. And systemic examination, chest, bilateral normal breath sounds, no added sounds, and even the CVS were normal. And here a sublabel biopsy was taken at AIIMS New Delhi under general anesthesia in October 2021. And again, the patient had received one cycle of VAC chemotherapy after the biopsy. So again, assuming that the possibility of a malignancy at that time. But like in the first case, when chemotherapy was also given outside, after the first visit here in the pediatric oncology, there was no significant reduction in the swelling or proptosis was noted following the chemotherapy first cycle of VAC chemotherapy. But the child still did not have any further bouts of epistaxis. And in the third week of November 2021, the patient was again started having these problems in the third week of November 2021 with difficulty in breathing, which was noticed by the parents, excessive snoring in the supine position, noisy breathing even at rest, and with chest retractions and irritability. And child was brought to because of these issues, the child was brought to the emergency department on 1st of December 2021. And that time the child was conscious, alert but irritable. Pulse rate was this time higher, 118 beats per minute, and also increased respiratory rate, last time per minute now. And definitely gross stutter was present. And it was associated with intercostal, subcostal, and suprasternal retractions. So definitely there was difficulty in breathing for the child, but the child was not cyanotic still, and maintaining saturation of 95 to 99% at room air. But stutter was definitely one important finding that time. Local examination, the same findings as regards the eye, the proptosis of the eye, the bulge in the nasal dorsum was there, and there was also mass in the nasal cavity, which was seen before on anterior rhinoscopy. But more importantly, this time there was a bulge on the right side of the soft palate, which was pushed down, and the tonsil was pushed inferomedially and causing narrowing of the oropharyngeal airway. And this obviously explains the stutter with which the child had presented this time. But the other findings were still the same. Most certainly the mass had increased in size, gone more posteriorly, involved maybe the infratemporal fossa or that area, and there was a bulge in the soft palate. But as such, the larynx was normal on fiber optic laryngoscopy. But to give relief for the airway and to secure the airway, an emergency tracheostomy was performed. So this you can see the child. You can see the tracheostomy is in situ. The eyeball is bulging. The cheek is full. The nasal dorsum also widened. I can show in the next slide here. It's the right eye shows the abaxial proptosis. It is pushed infrolaterally with restricted eyeball movement in the medial, superior and inferior gaze. The pupil was dilated, non-reactive to light. Left eye was normal. You can see the widened nasal dorsum along its upper third. There's a clear-cut fullness of the right side cheek, and it was more of a bony hard swelling, and the tracheostomy tube is in situ. And as I mentioned about the oral cavity oropharyngeal examination, that there was a bulge along the right side of the soft palate which was pushed down, with the tonsil being pushed inferomedially and causing narrowing of the oropharyngeal area. Further investigations which were done over here, the CBC was 11.3. You can see the hemoglobin was 11.3. The total count was raised 16,850, and 4.74 was the platelet. Urea creatinine was 12, so that was normal. Liver function tests were normal. Chest X-ray rest were normal. I'll just go to the CT scan which was done for the PNS, orbit, and the brain. We have the date was 18th of September 2021, which was done the previous one. It showed a very clear-cut right-sided sinonasal mass, which was involving the nasal cavity, the ethmoid complex, the orbit, the maxillary antrum, and the septum was pushed to the opposite side. If you have a marker, a pointer. And there was a heterogeneous enhancement, which was more. So you can see this is a right sinonasal mass, which is involving the right nasal cavity, the ethmoid complex. It is extending into the orbit. It is going into the maxillary antrum, and the septum is pushed and is gone to the opposite side. But it's a heterogeneous enhancement, and it is more at the periphery. But along with that, there are certain septations which can be seen, and there are central areas which are necrotic areas, which are non-enhancing. And definitely you can see compared to the opposite side that the eyeball is pushed out. So there is proptosis, which is caused by the mass. And the lesion is also reaching posteriorly up to the area of the nasopharynx. It's also involving the infratemporal fossa. We got further cuts. These are the coronal contrast cuts, which show the right sinonasal mass again in the nasal cavity, ethmoid complex, right maxillary antrum. It's pushing the septum to the opposite side. And there's erosion of the medial and inferior wall of the right orbit. You can compare it with the opposite side. You can understand that the orbital walls are gone. And the skull base erosion, again, you can compare to the normal side. It is present, but most likely there is no direct intracranial involvement per se, reaching possibly up to the level of the dura. But lesion is also reaching posteriorly up to the nasopharynx. And you can see that it is eroding the base of the pterygoid plates. It is also extending, eroding the lateral wall of the sphenoid sinus and going adjacent to the cavernous sinus. There is bowing of the posterior lateral right maxillary wall. You can compare it again. You can see this bowing over here. The right side, the maxillary wall laterally, and you can see some palatal erosion inferiorly, which can be seen. So this you can see on CT scan. MRI, which was done on 25th of August 2021. Again, it shows these are the T2 images that we have got. By the CSF, you can tell these are the T2 weighted images. It shows again a right-sided sinonasal mass, which is heterogeneously enhancing. There are predominantly hyper-intense areas, but there are septations which are hypo-intense or iso-intense. And again, extent was involving the right nasal cavity, the ethmoid complex, the maxillary antrum, which also has retained secretions, and involving the right orbit. Again, superiorly, there is skull base erosion, which can be noticed. It is coming right over here. But again, it looks like that at the most it might be involved up to the dura, but there's no intracranial involvement as such in the parenchyma. There's involvement of the infratemporal fossa, and again, the palate, you can see it's coming over here. There's a bulge. Possibly there is a palatal erosion or just coming very close. Posteriorly, if you can see over here, we are going almost up to the sphenoid sinus. We can see some retained secretions here in the sphenoid sinus. As I said again, in the skull base, you can see no clear-cut intracranial extension as such, but orbit is involved, and there are presence of fluid levels within the soft tissue mass in the sagittal cuts, which suggest various retained secretions. A PET-CT was done in October 2021, and these cuts, these are the trans-axial fused FDG PET-CT images. Again, the cut that I've got is that axial cut, heterogeneously enhancing. You can see not very much enhancing, but certainly in the peripheral areas, enhancement can be picked up. Enhancing rights, some few septations are seen, but there are necrotic and areas in the center, and the signal is possibly greater metabolism in the periphery. but we cannot make any comment on the regional or distant metastasis on this. So there were 3 biopsy reports which were provided. There was one which was done, the first biopsy which was done at RML on 24th of July 2021, and this showed foci of fragments of respiratory epithelium and tiny fragments of fibromuscular stroma. And there were occasionally scattered atypical cells infiltrating the fibromuscular stroma. The cells showed scant cytoplasm, hyperchromatic pleomorphic nuclei, and inconspicuous nucleoli. But I think they had to repeat it. And this time it showed fragmented core, which was ulcerated along with areas of hemorrhage and fibrin. And few cores showed proliferation of spindle cells, that is important, along with hyperchromatic nuclei and eosinophilic cytoplasm. So this point again was highlighted that showed strong cytoplasmic activity for SMA, smooth muscle actin, and weak patchy positivity for desmin. Possibility again of acute inflammation granulation tissue, inflammatory granulation tissue, but the possibility of rhabdomyosarcoma could not be ruled out based on that. And the third biopsy again, September 2021, which showed blood clots, fragments again of fibrocollagenous tissue, lined by respiratory epithelium with squamous metaplasia. And there was areas of granulation tissue, chronic inflammatory infiltrate, and few small bony bits were also included in that, along with trabecular bone and fibrosis in marrow space. And there was no clear-cut neoplastic lesion seen in that biopsy. So that was the third one. So to summarize, here we have a 1-year 4-month child with a 6-month history of a right nasal mass. The child had presented with epistaxis as the only symptom as far as the nasal symptom was concerned, but child also had proptosis, loss of vision, and a facial bulge. It grew rapidly. We know that based on the history with which the child had come. There was definite bony erosion in the orbit, the skull base, infratemporal fossa involvement. Multiple biopsies were done. The second one had suggested the possibility of a rhabdomyosarcoma, and twice chemotherapy was given. One cycle of cyclophosphamide-based chemotherapy and one cycle of VAC chemotherapy, but unfortunately there was no significant improvement following the chemotherapy. Obviously, the child, when she came in December, required an emergency tracheostomy for airway control. So now the important part, the differential diagnosis. Just to go to a few points, pediatric, these kinds of lesions, suppose it's growing very fast, you have to consider a malignancy in the first place. Whether the patient received 2 cycles of chemotherapy, responded clinically, I'm saying, what finally turns out will always be interesting for all of us to know. And histological surprises are something which we always get, especially in referral centers. But the common things come commonly. So that's why when I start my differential diagnosis, I would rather keep rhabdomyosarcoma because it is otherwise also the most common malignant tumor in children. Very often the kind of presentation that was seen in this case, we see often being referral center, even in AIIMS Raipur. Last year only we had a similar child, same problem, the orbit had the problem, then the facial swelling and required a tracheostomy, finally diagnosed as rhabdomyosarcoma with combined modality treatment. The other possibility I've kept is Ewing's sarcoma. Again, we do come across these patients of Ewing's sarcoma, and as such, malignancies of head neck region in children are rare, but whenever they occur, the commonest is rhabdomyosarcoma. And rhabdomyosarcoma otherwise is also the most common of the solid tumors in the pediatric group, the malignancy. We do keep the others, like especially we keep the mesenchymal tumors rather, and they could be Ewing's sarcoma or a neuroblastoma. Yes, other conditions, sometimes even lymphomas can present in this area, in the orbit, in the ethmoids, in the maxillary antrum. The other ones are not necessarily malignancies. It can be ossifying fibroma or giant cell granuloma, histiocytosis X. These occasionally do come across. I mean, these are mainly, if you see case reports, they won't be so commonly seen. Sometimes esthesioneuroblastoma, otherwise commonly seen in adults. Not that we don't see these cases in adults. Similarly, osteosarcoma is possibly the commonest bone sarcoma otherwise, but relatively rare in the head neck region and even more rarer in children per se. And I've kept others just to complete the list, whether it's osteochondroma or chondroblastoma, aneurysmal bone cyst, head neck cell neoplasms. This is just to complete the list. So again, I would say common things come more commonly. The, they were not able to demonstrate rhabdomyosarcoma. A couple of things I think which were important was it stained positively for SMA and Desmin. So maybe some component of smooth muscle was possibly there. And there are rarer tumors like myopericytoma and all. You can show similar pictures, but they're rarer ones. So we don't keep them otherwise in the differential diagnosis. I wanted to just go to the points which mentioned rhabdomyosarcoma. Otherwise, as I mentioned, it's the most common sinonasal malignancy in the pediatric age group. Early onset is usually the embryonal variety. As we have seen in this case, also very rapid growth. Involvement, these are the common sites of orbit, nasal cavity, nasopharynx, paranasal sinuses. And that is the site was again in our case also similarly. In usually it is the ethmoids, in that case in the PNS. Similarly, the pterygomaxillary region, infratemporal fossa can get involved quickly in these cases because it grows very rapidly. And usually it shows a poorly defined homogeneous mass will be seen on the CT scan and MRI. In our case, it was a heterogeneous mass, but it's not so clear cut anyway. And usually it will show some small blue round cells and occasional spindle cells. The point, of course, against, as I mentioned, was the heterogeneous mass seen on CT or MRI and no response to chemotherapy. Certain tumors, again, if we see, fall into more of a gamut. I think the pathologists would label them better as the small blue round cell tumors. And these are again more often seen in children, malignant tumors, and they stain blue on routine H&E stains. But they could include the rhabdomyosarcoma or the AIIMS or the neuroectodermal tumors or neuroblastomas. Again, so many of them can be actually included in this cluster of these small blue round cell tumors. So I think, again, I'll go back to this differential diagnosis, where I would rather like to keep rhabdomyosarcoma, AIIMS, neuroblastoma in that order, because they are the more common ones and we see them more often. But nonetheless, as I mentioned, histological surprises do occur, and we'll be very keen to know how it proceeded further. Thank you. Is there any questions?
Thank you, sir, for that excellent discussion. Since this patient was initially seen in pediatric oncology, Rachna ma'am, would you like to comment on your first impression when you saw the patient?
Good afternoon, everybody. I think the history and the presentation has been covered. But yes, when we saw the child first time, it was a small child, about 1.5 years old, with a big neck mass. And I think the presentation was far worse than what the snap which you showed. It was a huge mass. It was a neck mass, and there was feeding difficulty, breathing difficulty. All was there, rapidly progressed, and we are actually unable to proceed with the biopsies. And an attempt to review the previous biopsies was done. So our first clinical impression was an SMS, the way the child was, the way we label it as a superior mediastinal or superior, more of a superior vena cava syndrome, and then we were hunting for the causes. And then of course, RMS was our first clinical possibility. So the common protocols are that you have to handle the emergency first, and meanwhile, in parallel, run with the diagnostic workup. So the radiology team and the pathology team were uh, sort of working together, and Manisha would discuss later. Our first radiological impression was a RMS, and yes, we did put the child, but then we were awaiting our histopathology reviews and a fresh biopsy. And if I can recollect correctly, yes, our first impression was a RMS. So awaiting a definite report, we do want the child should not worsen after that the child is presented to us. So we give a empirical and sort of chemotherapy, which would be of a broad spectrum, and that is why cyclophosphamide was chosen as a drug. And then subsequently, there was not much of a response. Yes, the team did feel that there was some response in between, but no dramatic responses. Along with, I think even we used steroids. That is our first line, along with cyclophosphamide, if I recollect correctly. And then, of course, yes, the response was not so dramatic, and the attempt was made to review and do a biopsy. And meanwhile, the plan was to redo a biopsy, and then the child presented to the emergency, and then the tracheostomy was done. That was, and while all that was planned, we that is a protocol. We counseled the family that the radiology and the clinical and the pathological sort of discussions are pointing towards the RMS. So we gave him the first cycle of VAC after counseling and documenting it. So that was how we worked on. But later, of course, it turned out to be then I think reveal the diagnosis. And yes, that was what I have to add. Thank you.
Alok sir, would you like to talk about when the patient presented to ENT?
I think it's been a brilliant session. Many congratulations. Certainly, we were flummoxed by this patient. It wasn't easy at all, and the challenge of having such a rapidly progressive situation, wherein it was pretty obvious that you didn't really have too much time on your hands with regard to moving forward. Our first diagnosis was a rhabdomyosarcoma, just like yours. Your slide with the list of differential diagnosis is very revealing. I think really educative, because you have. But in the clinic situation, we didn't really think that far. In the clinic situation, you move further. And yes, sort of this patient went on with treatment for a rhabdomyosarcoma. It was only with the disappointment with the treatment, when we didn't really get a response, that further evolution occurred. And she'll tell us about that, of course. It is. These are the DDs, but if you look at the 3 biopsies, then one of them from RML did indicate a possible rhabdomyosarcoma, which was it cannot be ruled out. Be ruled out. I quite agree with you. We had Peanut and we had Wilms on our DD. Well, they respond to different chemotherapy. Yes, yes. Yeah, they respond to different chemotherapy. So ultimately, we were left to look at radiology and we were left to look at pathology. Very unusual to have a benign condition with such a rapidly progressive disease. There is a couple of DDs which can progress quite rapidly. Back the slide there, then we can run through that. Let's just look at his last slide with the DDs. You have it out there?
Yes.
Are there any suggestions from the house? Any thoughts, suggestions? So these are all the DDs out there. Certainly, Ewing, this is the neuroblastoma, PNET, round cell tumors was very much on the cards. Lymphoma, osteosarcoma, not so great on the cards. It's in the DD, but not as per the site. I mean, you generally see them on the skull or on the ears rather than here. Aneurysmal bone cyst, certainly feasible because bleeding, mass lesion, but just maybe a little bit too aggressive and the child too young. But ultimately, we failed with our initial medical diagnosis, and it was biopsy and radiology. Radiology did give us some hints. I don't want to quite bring them up now. Can you tell us about what you thought in terms of radiology?
I would not like to do it because this is kind of revealing. I'll just show the case. So here we have this CT as well as the MRI. So this is the CT axial image, contrast enhanced CT, as well as the sagittal. This is the coronal image, and this is the sagittal image, and this is the bone window coronal deformated image. So what we see is a very expansile mass lesion, and it looks very aggressive. It is so aggressive that we cannot see the cortex. The bony cortices cannot be well appreciated. So it is very difficult to say whether they are eroded or it is because of this ballooning effect. But it is a bony origin mass lesion arising from the right maxilla. And we can see large enhancing component at the periphery and few non-enhancing component, as sir pointed out. So it can be a necrotic tumor, very high grade, originating from the bone. But this non-enhancing component is quite big, and of note is that what we see, that the child is supine in the gantry. So this is the dependent area on the posterior aspect. On the posterior aspect, we can see that there is some horizontal kind of levels, that is fluid levels. Although it was not that much appreciated on the CT, MR could show this better. So this is the MR, T2 weighted sagittal MR images. Here, this is the globe, and this is the blown up image. Here we can see this is the there are multiple loculi. So this is multilobulated lesion, expansile bony lesion, and this shows the fluid levels. So this is a dependent part, which is T2 hypointense, and this is the supernatant, which is T2 hyperintense. So that this kind of thing usually we see in cases where there is bleed, either pre-existing in some cyst or repeated bleeds. So this is a multiloculated osseous lesion which showed some amount of bleed within, and a very high grade malignancy or very high grade tumor can give rise to secondary this kind of loculi formation or ABC formation, but that is the matter of dispute, whether it was a primary tumor to begin with, very aggressive, which has bled within, or it is just a sac of bleed. Yes, sir. And here also we, yes, yes, this kind. Hmm. So this is a necrotic, big necrotic tumor-like lesion. So this part was showing uptake on the FDG PET, and this central part, the necrotic part, that was not showing enhancement.
So one of the DDs was also that this could be a metastatic mass, and part of the reason for doing a PET was also to look at if there was any other primary which was sending. But maybe you can get back to the PET scan, and Dr. Bal can comment on what we see. This was the solitary lesion which came up on the PET.
That is what I was talking about. The rapidly growing peripheral and central necrosis, that glucose metabolism is all around the cell. So it is indicating that it is a rapidly growing tumor. The blood vessels do not catch with the growth of the tumor, so that will be central necrosis. So that multicameral cystic site is nothing but a necrotic part of the tumor.
Primary bone, because we cannot see the maxilla. Had it been a primary soft tissue tumor, we could have seen the mass effect on the bone, or the bone must have been compressed at the side, and this kind of expansion that it is causing, primary osseous lesion. From the ethmoid. From the medullary and cortex, it is very difficult to point out, that we cannot say, but probably it is not from soft tissue, not from soft tissue.
Thank you everyone for your comments on the clinical imaging and PET-CT finding. I'll go on to the biopsy. This is the fourth biopsy that was done here. This is the fourth biopsy that was done here in ENT. So you can see that what we received were multiple fragments of tumor tissue which appear predominantly solid. There are some slit-like vascular channels which are seen in this, and there is some here. And on higher magnification, you can see that the tumor cells are spindle shaped with abundant cytoplasm. They are arranged in fascicles. which are intersecting, and in other areas they are arranged in a storyform pattern, which refers to the radiating spokes of a wheel, which you can see here. Interspersed between these tumor cells at places which look like staghorn vessels because of their branching antler-like appearance, which are described in a number of soft tissue tumors. In this site, predominantly in glomangiopericystoma, solitary fibrous tumor, a number of such soft tissue tumors. What is striking here is the presence of few multinucleated giant cells, which are distributed haphazardly between the spindle shape. So this again is a higher magnification of the same, along with the spindle cells and the giant cells. You do have some inflammatory cells which are also scattered in between the tumor cells. You can see that these tumor cells, despite what the clinical picture look like of a very aggressive malignancy, what you see here is that these cells are bland. There is no nuclear atypia. There are no mitosis. In the entire slide, I found 1 or 2 mitosis only. And in one focus, there was an aggregate of giant cells with a lot of hemorrhage. As you can see here, a lot of RBC extravasation between the spindle cells and these giant cells, which look like osteoclastic giant cells. And in some areas, in some of the fragments, you can also see, what you can see here is this eosinophilic acellular material, which is osteoid, and there are some cells embedded within it, and also some woven bone which has formed and is starting to mineralize. So to summarize the histological features at this point, we have a proliferation of spindle-shaped cells with interspersed inflammatory cells and few osteoclast-like giant cells. There is some osteoid and woven bone at the periphery of some of the fragments. And initially, when I saw this biopsy, I was not sure whether this is part of the tumor or if it is a reactive process due to infiltration of the tumor into the surrounding bone, considering that clinically and radiologically it looked like an aggressive malignancy. So that was a question. And so the approach here would be to look at what are the spindle cell tumors you can see in this region, as well as what are the giant cell rich lesions you can encounter. So this is a table which lists out all the spindle cell tumors you can see in the paranasal sinus, nasal paranasal sinus region. And I'll just break down the table here. We talked about rhabdomyosarcoma. When we talk about spindle cells, there's a variant called spindle cell rhabdomyosarcoma, which can show this kind of architecture. Usually has atypia and mitosis, but on occasion, it can look very bland and deceptive. Interestingly, recently a new entity has been defined, which is intraosseous rhabdomyosarcoma of the head and neck region, which is characterized by a distinctive genetic alteration. So we won't want to exclude that. Next, you have fibromatosis, which is a spindle cell tumor, which is benign. I mean, which looks quite benign, but we don't have a collagenous matrix, so maybe we can exclude that. It's unusual at this location and this age group. The presence of these plump spindle cells, which look like fibroblastic, myofibroblastic cells, and the admixed inflammatory cells raises the possibility of an inflammatory myofibroblastic tumor. The morphology doesn't fit with that of a schwannoma or meningioma. We can exclude those. Another tumor which can show this kind of features, which also shows the presence of osteoclastic giant cells, foci of calcification, a grungy matrix, smudgy matrix, is phosphaturic mesenchymal tumor. This tumor has a characteristic clinical presentation, and it, although usually seen in adults, it may occur in young children. We've recently seen a 5-year-old child with the same. Other tumors in this region, the morphology doesn't fit. The age group is, these are seen in adult females, not likely to be this tumor here. Solitary fibrous tumor, again because of spindle cells, the staghorn vasculature, but again we don't have a collagenous stroma, you don't have alternating hypocellular areas, and these tumors do not show the presence of giant cells. Next, we go on to what are the tumors in the head and neck which can show giant cells. Osteoclastic giant cells can be present in a broad range of benign and malignant soft tissue neoplasm, either as a reactive component that varies widely in abundance, but sometimes constitutes the bulk of the tumor. So this table in this recent article delineates what are these lesions. You have giant cell tumor of bone. Very unlikely at this site, you have aneurysmal bone cyst. Central giant cell granuloma, which is the first possibility that I thought of with these histological features, although the location is unusual. It's mostly seen in the mandible. Tenosynovial giant cell tumor is seen in the temporomandibular joint, so we can exclude that upfront. Again, phosphaturic mesenchymal tumor comes in here as well. So it's there in the spindle cell as well as giant cell rich lesions. And lastly, you have brown tumor of hyperparathyroidism. So a little bit about each of these. Central giant cell granuloma is benign, often locally aggressive tumor, which is almost exclusively seen in the jaws. and it more commonly affects the mandible in female pediatric patients, more than half of whom are seen in the first 2 decades of life. And in the mandible, usually it's unifocal in the anterior mandible, may be seen in the maxilla as well, and rarely in the sphenoid and temporal bones. It presents as a slow-growing, expansile, unilocular or multilocular lesion with thinning of the cortex, and they are well-defined, generally do not show cortical invasion, but aggressive behavior has been reported in up to 30%. You see the morphology here, we have an unencapsulated proliferation of aggregates of osteoclastic giant cells in a hemorrhagic cellular spindle cell stroma, which look quite similar. These osteoclastic giant cells may be seen dispersed or arranged in clusters around small capillaries, and these features are identical to what is seen in cherubism, aneurysmal brown cyst, and brown tumor of hyperparathyroidism. The stromal cells are fibroblast-like. You will see frequent areas of hemorrhage, hemocytin deposition, and fibrosis. Occasionally, osteoid deposition and woven bone formation may also be present. These tumors are characterized by mutations in the KRAS, FGFR1, or the TRPV4 genes, which all lead to MAP kinase pathway activation in 70% of sporadic tumors, and germline mutations are seen in certain syndromes. There are no specific markers which are going to aid in the diagnosis, because the osteoclastic giant cells will stain with CD68, which indicates their lineage, while the fibroblasts will be positive for smooth muscle actin. Next, we come to cherubism. It's a rare familial syndrome with autosomal dominant inheritance, which has a gain of function mutation in the SH3BP2 gene in 80% of cases. And the mandible and the maxillary bone is replaced by a fibrovascular stroma, which contains giant cells again and sparing the condyles. But this is a bilateral condition, as you can see here. This process usually starts in early childhood between 2.5 to 5 years of age, and they can regress after puberty. On imaging, you see multilocular radiology. This is the morphology again. Spindle to ovoid cells, osteoclastic giant cells, and thin-walled blood vessels can be seen with giant cells aggregating around the small vascular spaces with hemocytin depositions. The histological features are similar to that of central giant cell granuloma, and only thorough history taking, including family history and the presence of bilateral lesions, is what will help you make this diagnosis. So we can exclude it in this case. We didn't have bilateral tumor. Next, we come to aneurysmal bones. These are cystic or multicystic expansile osteolytic tumors, which are composed of blood-filled sinusoidal spaces lined by fibrous septae, which contain osteoclast-like giant cells. Usually seen in the metaphyses of long bones or in vertebrae, they exhibit locally destructive behavior. About 1 to 2% of them are seen in the head and neck, where the majority are seen in the mandible. Also can be seen in temporal, occipital, frontal, and orbital bones, but extremely rare in the paranasal sinuses. Almost all reported cases have a typical appearance of ABC, as seen here, with hemorrhagic cystic spaces with fibrous septae, but a rare solid variant is described. Morphologically, what you see are these septae, which contain again a spindle cell proliferation and osteoid as well as osteoclastic giant cells, and abundance of reactive or woven bone, areas of calcification, and zones of chondroid metaplasia are more frequently seen in aneurysmal bone cyst as compared to the other lesions that I've discussed. As I mentioned, the solid variant is seen in 5% of cases. What is important is the molecular alteration, that is, a fusion of the USP6 gene with one of several fusion partners is identified in this tumor, and it is not seen in what are ABC-like areas in other primary tumors, which helps to distinguish from those. Next, phosphaturic mesenchymal tumor is a rare bone and soft tissue tumor associated with progressive hypophosphatemia, phosphaturia, and tumor-induced osteomalacia. When these tumors secrete a phosphatonin FGF23, leading to renal wasting of phosphate due to FN1 FGFR1 or FN1 FGF1 gene fusions, which dysregulate the FGFR1 pathways. These patients have a typical clinical presentation, which is that of progressive muscle weakness, bone pains, and pathological fractures, none of which were available in our patient. These tumors are often small and missed on imaging, and they require DOTA-8 PET CT to pick them up. The spectrum of histological features again is the same. Land spindle cells, hyalinized smudgy matrix, calcification, variable number of osteoclastic giant cells, and staghorn blood vessels. In the head and neck, paucity of smudgy matrix, grungy calcification, and osteoclastic giant cells may make it difficult to identify. So they are usually diagnosed as ossifying fibroma, non-ossifying fibroma, osteoblastoma, hemangiopericytoma, prior to the identification of this as a distinct entity in 2013. On immunohistochemistry, they would be positive for SADV2 and CD56, which would help to make the diagnosis. But Ultimately, the diagnosis can only be made in the presence of raised serum FGF23 and the characteristic clinical picture. So we're excluding this because we didn't have the typical clinical findings. Lastly, giant cell tumor of bone. It typically affects the epiphysis of long bones and is seen in skeletally mature young adults with female predilection. Less than 1% are seen in the craniofacial bones. When they do occur, it's in the sphenoid, frontal, temporal, occipital bones rather than the jaw bones, and they do occur in arise from the thyroid cartilage following ossification. So what you see here are numerous osteoclast-like giant cells with interspersed stromal mononuclear cells. The giant cells in giant cell tumor are larger with more abundant nuclei, more than 20 in number, and these cells are more uniformly distributed throughout the lesion. And the mononuclear stromal cells are the mitotically active component. You can also see aggregates of histiocytes, fibrosclerotic areas, secondary ABC-like areas with hemorrhage, hemocytin deposition, osteoid deposition following biopsy, giant cell depleted areas, and necrosis can also be seen, which might give rise to a similar picture. But these tumors have a characteristic mutation in the H3.3 H3F3A gene in 95% of cases, and this can be detected by immunohistochemistry using antibodies against the mutant protein. You can see here that the stromal cells would show positivity for H3F3A while the giant cells are negative. Round tumor of hyperparathyroidism also has the same morphology and should be kept in consideration, but there was nothing to suggest that there was no history or clinical features to suggest this possibility, which is why it was not considered. When we're talking about malignant lesions with giant cell rich osteosarcomas are osteosarcomas which contain numerous non-neoplastic osteoclasts like giant cells distributed throughout the tumor. On low part, they can mimic a giant cell tumor or a central giant cell granuloma, but on high part, you would see a lot of mitotic activity, nuclear pleomorphism, and which were not present, so we can exclude it. Telangiectatic osteosarcoma can mimic aneurysmal bone cyst, and we saw those multiloculated fluid levels in the imaging. So this also needs to be excluded. Again, the cells would show malignancy features, so this is excluded. Lastly, you have fibroosseous lesions, which can have secondary ABC-like areas. In children, these tumors are more common in the craniofacial bones and should be kept as a possibility. Fibrous dysplasia would show fibrocellular stroma with curled spicules of woven bone and a bizarre configuration, and they lack an osteoblastic rim. Whereas ossifying fibroma would show a fibrous stroma with anastomosing bony ossicles and trabeculae, immature osteoid of mature bone, and cystic hemorrhagic degeneration leading to ABC-like changes can be seen. But with these features in mind, we didn't see any of the features of any fibroosseous lesions. So what it narrows down to is a central giant cell granuloma, aneurysmal bone cyst, or maybe an unlikely possibility, a giant cell tumor with chemotherapy-induced changes, because this patient has received chemotherapy, which does causes depletion of giant cells in giant cell tumors. We performed immunohistochemistry, and desmin, myogenin, and MyoD1 were negative, excluding a rhabdomyosarcoma. Smooth muscle actin was positive in the cells, however, ALK was negative, which ruled out a inflammatory myofibroblastic tumor, but shows that these cells are possibly fibroblastic or myofibroblastic in origin. CD68 highlights the giant cells. H3F3A for giant cell tumor of bone was negative. CD56 was negative, excluding the possibility of phosphaturic mesenchymal tumor. But the cells were majority of the cells were positive for SADB2, the spindle cells, and the giant cells were negative. And SADB2 was seen aligning the scenes of osteoid was present. SADB2 is positive in those cells, indicating osteoblastic activity. So on further looking at the biopsy further, some of these fragments appear to be septae, and they have osteoid in these septae, and these septae also show the presence of giant cells. These features, and then you have more abundant osteoid in some areas, with abundant osteoid, a little chondroid appearing stroma in which the cells are embedded, small sinusoidal channels in the solid areas. The features are those of an aneurysmal bone cyst. So with this, Dr. Hitesh, could you tell us on the approach for selection?
So, aneurysmal bone cyst was a rare tumor, especially at this age group patient, and it is quite rare in this area. So we reviewed the literature, And the literature suggests that it's a benign expansile mass lesion and surgery is the treatment of choice. Anyhow, it's very slow growing tumor. So what are the features in this patient which suggests us to go for surgery? Is a progressive lesion, as a lesion was progressive, visual impairment, as a patient is not responding to the objects which are showing on right side, and sleep apnea. Because child are generally absolute nose breather, so this patient have problem with breathing. And during the course in the hospital, when we took the biopsy and subsequently we followed the patient, worsened during that period. So we did the tracheostomy, so neutralize the severity of the disease. And for surgical approach, as a diagnosis is still not clear, it's primary or it's secondary, because there is a variation. There is a solid component in between the in radiology. It shows it's solid and cystic both components. So possibility of primary lesion may be within the this lesion which we identified in the sinonasal region. So in view of severity of disease, we took the diagnosis, and for approach, we select open approach because diagnosis is not clear, and because of vascularity of tumor and because of the extension of tumor lateral to the mid-orbital, mid-pupillary. So this was an incision. Weber-Ferguson incision was used as the tumor is extending inferiorly and laterally to the mid-pupillary line, and it's combined with the Lynch-Howard extension because it was extending till the level of skull base. And this was the exposure. Incision orbit, as the disease is benign, it was not found infiltrating within the orbital tissue. Periorbita was found intact. So we could separate the orbit from the primary tumor. And as the tumor was very vascular, when we review the literature, so we took control laterally, first the maxillary artery and anterior and posterior ethmoid artery, so that the vascularity can be reduced. In terms of margin, we could separate easily from the palatal surface, from the septum. As the septum was pushed, it was not eroded by the disease, and could separate easily from the infratemporal fossa. The tumor was found attached at the level of the skull base. So while separate, as a bone was already eroded, while separating the tumor, there is a dural breach, and we repaired during the surgery. Some amount of bony irregularity was present at the level of the skull base. So we kept this patient for rather than doing harm, as the literature suggests, if possible, gross total removal is good enough. If not, then subtotal is also good enough. Because literature is not clear which entity should be done, as the outcome of both entities are almost equal. Some literature also shows a spontaneous regression of the remaining part of the tumor. So subtotal resection was done.
Thank you.
The entire orbital tissue was pushed laterally. The periorbita, neither optic nerve, it all spread. Because we performed the biopsy at here, and we confirmed with pathology, because it was still not clear. So anyhow, we will take the biopsy because the child was very small, so it's not possible. We are going again for surgery. We decided if we can take out this complete. Child will. Yes, yes. Both possibility we kept in our mind, but
We'll take a look at the excision specimen. I am going to exceed my time. I request you to please bear with me. So what we received was a predominantly solid tumor, and you can see there's a peripheral shell of woven bone here, which is calcified, which is why it appears blue. Within the tumor, there are few cystically dilated blood-filled spaces that are seen here, but a lot of pink extracellular material here, which is osteoid, as well as some filamentous trabeculae of newly formed bone. These dilated spaces filled with blood are devoid of an endothelial lining or smooth muscle. So they are okay, they're devoid of endothelial lining, which is what you see in an aneurysmal bone cyst. In the solid areas, you have areas where there is abundant osteoid deposition seen here, as well as cellular areas, which were the spindle cells that we saw in the biopsy. Foci of hemorrhage are present. The cells are again on high magnification, arranged in a patternless or vague storiform pattern. Inflammatory cells are present. Again, they lack nuclear atypia. So these are similar features to what we saw initially. There was just one focus in all the 6 slides that were made where there was a prominence of osteoclastic giant cells and hemorrhage, which is what you expect to see in an aneurysmal bone cyst. There was evidence of osteoblastic activity. You can see that there are osteoblasts which are rimming these seams of osteoid. You can see the osteoid is getting mineralized here, which is basically getting calcified to form bone, which you can see here is forming woven bone by the haphazard arrangement of the mineral in this bone, as opposed to lamellar bone, where you can see these nice lamellae. This is for the junior residents in pathology. Is woven bone, and this is lamella bone on polarized microscopy. So this is a characteristic feature. You have these seams of osteoid which are forming narrow trabeculae of what is called blue bone with intervening parallelly aligned spindle shaped cells, which are seen here. This is typical of aneurysmal bone cyst. And some areas had more extensive mineralization, forming lace-like trabeculae, and you can see these cystically dilated blood-filled spaces. Focally, you could see that the stroma was more bluish appearing, which is why it is called as having a chondroid aura. And this again is a typical feature, but because this tumor was predominantly solid with only very few cystic areas, it's a solid variant of aneurysmal bone cyst. Here you can see this is the mucosa of the sphenoid sinus, the bone of the sphenoid sinus, and the tumor is reaching all the way up to here. There was one specimen which was sent separately as posterior margin, and that is the sinus mucosa here, and you can see that this is the tumor which is reaching all the way here to what was sent as the posterior margin. To confirm the diagnosis, we performed fluorescence in situ hybridization using a USP6 break apart probe, and you can see here that there was a rearrangement of the USP6 gene. For my clinical colleagues, the USP6 gene is located on the 17p chromosome. When the gene, we have 2 different colored probes which bind to either end of the gene. So in a normal cell, you would expect that because the gene is intact, these 2 would overlap, giving what is a yellow signal here, or maybe red-green signals which are very close to each other. But when there is a rearrangement or a break in the gene, you would see that these 2 signals would split apart, which is exactly what we are seeing here, and this confirms the diagnosis in the present case. So, aneurysmal bone cyst has been described by Maria Dabska as one of the most interesting clinical and pathological problems among the morbidities of the skeletal system. Interestingly, Maria Dabska, gave an excellent description of this tumor in 1969, and she is one of only 2 women who has a tumor named after her. So she said that pathologists seldom have the opportunity to examine the entire tumor, which is right. This is what my residents looked at when we received the specimen. And you can maybe see some cystic spaces here, some hemorrhage, but you really can't appreciate much on this specimen. This is the gross that Dr. Maria Dabska described, where you can see she said that it looks like an inflated balloon with a raised periosteum with a thin osseous shell just underneath the periosteum surrounding the entire tumor, under which the bone was completely destroyed and replaced by a labyrinth of rounded cavities of various sizes filled with large quantities of liquid blood. The inner surfaces of these cavities are smooth and glossy. Some tumors resemble a sponge, while others are more fibrous with fewer cavities and look like Swiss cheese. Traditionally believed to occur due to sudden increase in pressure in the vascular bed at the site of a pre-existing bony defect or lesion, creating a blowout distension. In 1999, I cannot pronounce that, reported that the translocation of chromosome 16 and 17 was found consistently in ABCs, and this gene was identified on this chromosome. So this gene is normally expressed only in embryonic tissues and testis, But when there is a rearrangement and this gene fuses with a number of partners, what happens is that it binds to the promoter region of the partner genes, leading to a promoter swap mechanism, which leads to upregulation of the expression of this gene, which leads to activation of processes like intracellular trafficking, matrix degradation, and cell transformation. There's no fusion protein that is formed here. The most important partner gene is CDH11. Now, as I mentioned, when there is upregulation of the USP6 gene, it inhibits bone morphogenetic protein 4 and induces BMP inhibitors, which leads to inhibition of osteoblastic maturation, and also leads through NF-kappa B, it leads to increase in osteolysis, recruitment of inflammatory cells, angiogenesis, and tumorigenesis. This fusion has been demonstrated only in some proportion of the stromal cells. It's absent in the osteoclastic giant cells, the inflammatory cells, indicating that they are recruited to the tumor and are reactive in nature. If you search for aneurysmal bone cyst with solid, you find only 46 results on PubMed. It is extremely rare. It was first described in 1983 by Sanerkin, who said that it can be mistaken not only by the general histopathologist, but by the osteoarticular pathologist for a variety of other conditions, including sarcoma. Some form of sarcoma was diagnosed by pathologists at the source hospital or by osteoarticular experts on subsequent review. It was indeed difficult to persuade the referring clinician that the condition we are describing could have the benign course exemplified by these patients, and that conservative management was the correct course of action, which is exactly what I encountered in this case. Interestingly, out of the 4 cases in the first description, 3 of them showed some sort of extension or infiltration into the surrounding muscles. One case was from the ethmoid region and orbit. Morphological features, I think they've been well described. I won't take much time over it. These account for about 3.5 to 7.5% of all aneurysmal bone cysts. And what is important based on this location is that it is histologically indistinguishable from central giant cell granuloma, previously known as giant cell reparative granuloma. There's considerable controversy exists in the classification of giant cell rich lesions as solid ABC or giant cell reparative granulomas, especially in the tubular bones of the hands and feet. And what happened was that lesions in the appendicular long bones are called solid ABC, whereas those in the paranasal, the craniofacial skeleton, are referred to as central giant cell reparative granuloma. Some authors prefer to use a mixed term. So you can see here that for the same entity, both the terms have been used in various reports. But Agram et al. Showed that central giant cell granuloma and solid ABC are distinct entities when they demonstrated the USP gene rearrangement in the what was called giant cell granuloma of the hands and feet, and it is absent in gnathic giant cell granuloma. So they said that so-called giant cell granuloma of the hands and feet are truly solid ABCs, and that is what they should be classified as. And the terminology of CGCG should be restricted to gnathic lesions which have this morphology. Secondary aneurysmal bone cyst is the terminology that is discouraged by WHO classification, and the preferred terminology is ABC-like areas. It's seen in about 30% of ABC, and it can be seen in various benign and malignant tumors, including fibrous dysplasia and ossifying fibromas in the head and neck region. But it has been proven that secondary ABCs are molecularly distinct from primary ABC, and we demonstrated the presence of the USP6 gene rearrangement, which conclusively shows that this was not a secondary ABC with any other solid lesion, but a solid aneurysmal bone. There are a number of pitfalls in the diagnosis of solid ABC, both radiological and histological. Unlike ABC, solid ABC may be non-cystic, up to a third of them may be non-expansive. Multiple blood fluid levels are not always present, and the presence of the solid areas with blood fluid levels favors secondary ABC over ABC. The thin eggshell margin is often incomplete or absent in these cases. On pathology, the presence of osteoid in a fibrocellular stroma can lead to a diagnosis of fibrous dysplasia. When there is no marginal reaction, it has been interpreted as osteoblastoma, even osteosarcoma in some cases. Sometimes mitosis may be fairly abundant, leading to further suspicion of malignancy. From our department, we have a report of 2 cases which mimicked malignancy. There is only one report on the PET-CT findings of this tumor, that's solid ABC, and this was in a patient who was post-nephrectomy for renal cell carcinoma, and an elbow lesion showed intense uptake with an SUV max of 9.9, and the primary diagnosis that was considered was metastatic RCC. So they can show hypermetabolism. So what do we do When radiology and histopad doesn't help us, we go in for molecular testing, which is what we did in this case. It's not required in all cases of ABC, only in cases where with ambiguity in the histological features such as solid ABC. So we usually perform fluorescence in situ hybridization, but sometimes it might not be detected by fluorescence in situ hybridization, and you require next generation sequencing. Following the advent of these molecular tests, you can see there are reports of aneurysmal bone cysts, solid aneurysmal bone cysts in the paranasal sinus region, which were initially diagnosed as central giant cell granulomas, but on identification of this molecular alteration, they were confirmed as solid ABC. So to conclude, the differential diagnostic approach to giant cell containing neoplasm of the head and neck is multifaceted. It requires integration of demographic data, biochemical measurements, radiological imaging, histological evaluation, and molecular testing. Solid ABC is often difficult to diagnose, often mimicking malignancy, and is also difficult to treat. Recognition of its benignity is vital as it is amenable to treatment by local surgical excision. An erroneous diagnosis of malignancy would lead to unnecessary radiation and chemotherapy with its attendant risks, especially in this young age group. So we need careful clinical radiological assessment to tailor an appropriate surgical plan to prevent recurrence as well. And most recently, a possible role for denosumab, which is used for treatment of giant cell tumors of bone, has been suggested in residual and recurrent tumors. So again, back to Maria Dabska, she said that only an experienced pathologist can make a diagnosis of aneurysmal bone cyst from punch biopsy material. I am not that experienced, and I'm thankful to have my colleague Asit sir who made this diagnosis. Thank you, sir. Dr. Adarsh helped with the fluorescence in situ hybridization. Thank you to my radiology colleagues, Dr. Ashu, Dr. Manisha, and to my pediatric oncology and ENT colleagues for always providing challenging cases. Yes, sir. So when we see the sections, if I have not shown all of the sections, but most of the sections had completely solid areas. There were hardly any fluid fill, I mean blood filled spaces that were identified. Only those which I and those. There is no cutoff as such, but those septae that you see, we saw some in the biopsy, but we didn't really see some in the resection. It was solid, and also on imaging, you did see a solid component as well. So, up to yes, so this study which I showed here, they showed that about in out of all of the cases, few cases did not show the rearrangement by fish, but on next gen sequencing, it did show the alteration. So that's the thing. If it doesn't show by fish, you still suspect the diagnosis, you go for next gen. Yes. I didn't make the diagnosis. I know. I kept saying that the morphology is that of a central giant cell granuloma. In the head and neck, that is what I would think of, and it is histologically indistinguishable. So, exactly, yeah. Yeah, so no, not at all. No, sir, it does not. The ones which are reported as giant cell reparative granuloma in the hands and feet, they have that alteration. So they are actually solid ABCs. Yes, so what I thought on histology did not match with the radiological appearance at all. So that Yes, sir. It was there in your list of diagnosis. Hmm. That is why it's solid, sir.
Resembled very much. So
Dr. Hitesh, can you just tell the follow-up of the patient?
थोड़ी सी है, 5 minutes. So, sir, in follow-up, in early follow-up, PEC was removed on second day, and subsequently patient have no sleep apnea, no further deterioration of vision on other side. After PEC removal, there is no CSF leak and suture removed on 7th day, and this is the latest follow-up. Yes, sir. Visual improvement. RAPD was gone, and patient can appreciate object from right side, and ophthalmologist can document it's up to 6/24 in this. And this is a post-op cavity. Thank you. I would like to invite Professor Al.
So you have this mutation, and this is a germline mutation. No. So what can we tell about the prognosis now that she has this mutation? Can we expect this child to be stable? Can we expect this child to have, because there is some residual tissue that we have probably left behind there at the skull base, especially after the CSF leak. We have cleared the sphenoid. You showed us how the sphenoid has been cleared. The optic nerve has come back. We're a little bit worried there might be some.
Very few reports of solid ABC in this region, but solid ABC on the whole has been shown to have a slightly higher recurrence rate as compared to a conventional ABC. So ABC also recurs in about 25% of cases. In this, they say about 30-35% of cases will recur. So, considering that some amount of tumor might have been left behind, the patient needs to be followed up to watch for a recurrence. The gen-
Complication of a tracheostomy, but it's not a frequent complication of a tracheostomy. We would be disappointed if this child went that road. Very, very disappointed. Yes, should be now decannulating. We have waited a couple of months, and the child has no stutter stridor. The child is breathing well, functionally so much better. We'll now decannulate. Yes. So questions and comments, Dr. Hitesh. Comments?
For keeping the differential diagnosis of ABC, it was very much there. And when the radiologist told,
yeah, I think, like I said, you see, whenever we are discussing these cases, common things come first naturally because it was going very fast. But you should always keep your differential diagnosis. And I think now, since we have in hindsight, we always know that immunohistochemistry will always help us. So even if there are rarer tumors, I think subclassification will require a lot of support by our histopathology colleagues. And I think that's the best way forward. We get the correct report, then we can plan accordingly. Like in this particular child, if it is not an RMS, the child was diagnosed as ABC, child does not require chemotherapy or radiotherapy, and of course follow-up is obviously required, but at least the child is saved of that kind of other therapies which would lead to so many other problems. Yes, follow-up will always be required, but I think it only goes to show that everybody has to work together, whether it's the clinician, the radiologist, the pathologist, nuclear medicine specialist. I think all working together, and then we can arrive at the diagnosis. Yes, absolutely. Even benign lesions can grow very fast. Thank you.
Thank you, sir.
Thank you, sir,